Thank you. Who would like to come in? Luke.
Yeah, thank you very much. Just a quick question first to Ben and then to pick up that point. And can I ask, in your analysis, does it look at the productivity, and is it based on the productivity currently within the NHS, or is it based on improving productivity?
So we actually allow for, if anything, a hit to productivity, at least in the near term, from the need for ongoing infection control measures and perhaps the need for patients to be spaced out more, staff to change their PPE more often, all the sorts of things that slow down an already very busy team. So we've actually allowed for some additional costs from that. In terms of increased productivity, I think the healthcare system is extremely complex, and trying to put one number on what does productivity mean in healthcare is extremely difficult. So no, you could argue that, I'm sure you could make the case that with improved productivity you could see more people with the same amount of resources. We actually think that at least in the immediate term it looks like you'll be able to see fewer people with the same amount of resources. But clearly boosting productivity and finding ways to do more with less is going to be central to NHS recovery.
That's right, because there's trailblazing hospitals that are currently trying to get to 120% of their capacity. My local hospitals are one of that, so that's why I asked the question. I guess on that basis of history repeating itself, under Labour governments, one of the ways was to put extra funding in, and there's a big worry from politicians and the public. We're putting £36 billion in. How do we see in 3 years' time we're going to see actual improved access, improved speed to your operations? Are there any tangible thoughts about how you break that productivity down from a financial perspective?
I think that the Treasury writing such a sizable cheque to the NHS will clearly want there to be strings attached and there to be clear, identifiable targets and goals of things that should be achieved. I think that the ambitious national target over activity levels is a good example. Delivering a 30% increase in volumes of activity by the middle of the decade relative to pre-pandemic is ambitious, and that is huge, and that's something that you can measure the NHS against. So I think that those sorts of things are valuable. Clearly, as you delve deeper within the system and look at the individual specialties or hospitals or cases, they'll have to be different and flexible. But I think that on a national level, there is a level of ambition there, and I think that's to be welcomed, and also it should be something that we can hold the NHS to account and observe whether that's actually delivered.
That's really helpful, thank you. So that leads on to the question, given your background. Do you think the NHS is in a position to have time to think about the productivity? You already hinted at it perfectly in your example there over should patients get that care that's provided to them. Are there ways in which your organisation will have any thoughts about how we can improve that productivity, making sure the decisions that are right for the long-term care, but also right for the taxpayer and the NHS?
Good question. So I'd say, first of all, one of my biggest concerns, which I know the committee's talked about before, is headroom, and the amount of headroom that you have in the NHS to plan and consider changes to how services are delivered. I vividly remember visiting an A&E department. You couldn't take 2 steps, the general manager was showing me around, you couldn't take 2 steps down the corridor without someone popping out and saying, "Ben, where's my bed? Have you found my bed yet?" And eventually I just had to say, "Do you know what, you've got better things to do than show me around." So carving out time for headroom is one of the rate limiting factors. I think what we've seen in the systems we've been working with is probably 2 things. First of all, an understanding that systems are not magic. They will not solve all the problems facing an individual clinical team. So a real focus on giving teams support, whether it's through quality improvement training, on how do you take a patient pathway, and remove waste and really have the most streamlined, lean process possible. But the second thing, which I'd say has really been a feature of the last 2 years accelerated by the pandemic, is what as a system can we do that no individual organisation could do by itself. So things like designating this part of our system is going to be the place where we do vascular surgery at scale to deliver better efficiency but also better clinical quality and safety. Those are the sorts of, separating out those hot emergency procedures from cold planned procedures. Those are the sorts of moves that you're starting to see as a system, and also reducing duplication and waste and standardising how things are done. I think the system working aspect of how the backlog is going to be tackled is one of the factors that we didn't have 20 years ago under the new Labour government, when backlogs were being tackled in a different way.
Thank you. Laura Trott.
Thank you, Chair. And thank you both for coming. You've stated that you believe that the government funding will be broadly adequate to cover the backlog, but that huge uncertainties remain, and that one of the key uncertainties is the number of patients coming forward for treatment. Can you just talk the committee through what some of the other big uncertainties you think are, which would mean that this funding wouldn't be adequate? Ben first, if possible.
Sure. The biggest one we think is this question of how many of the missing patients remain. One thing I'll add on that before I move on is that the data so far, at least the national level data, indicates that there is no sense of a huge rush of patients trying to get in. The number of people joining the waiting list, at least in the national figures, is still below where it was. So in August, still 93% of where it was in August 2019. So there's no sense at which people are flooding forward to treatment. And I think that might be good if all you care about is the length of the waiting list, but you might be concerned about those people who perhaps aren't getting care that they might benefit from. Other big uncertainties, of which there are many, the other huge one, of course, is the future course of the virus and the extent to which that requires both people directly to be treated for COVID, the need for ongoing infection control, spending on PPE, all those things that we just cannot know with any certainty in advance. There are also uncertainties about whether, and if so, the size of any sort of cost premium associated with the, in economists speak, the marginal unit of care. So every additional person you want to treat, it might become more expensive if you're having to spill over into new facilities, or making great use of bank or agency staff, or using independent sector providers. Other organisations doing similar exercises have reached different numbers for those things. One final one, these people who return, these missing patients, if you like, who return, are they going to be in need of more intensive care? Are more of them going to need to be admitted than might previously expected because they've waited longer? Will some of those people's conditions just have resolved themselves? So will the treatment mix have changed, I guess, is the short version. There's all sorts of uncertainties about these things which we've tried to test